Okay, so we're going to go very quickly into introducing our very seasoned speakers. I told you that we have subject matter experts who are very skilled in this. They have extensive experience and have also the extensive training. I would introduce both of them and then we will start off. We have Dr. Cecilia Kootin-Sanwu. Dr. Cecilia, I've been rehearsing this name for 24 hours so that I pronounce it well. So please, you let me know how well I did. She is an endocrinologist / a dietologist at the Greater Accra Regional Hospital. She's also a fellow of both West African College of Physicians and the Ghana College of Physicians and Surgeons. She graduated from University of South Wales with a postgraduate diploma in endocrinology. She has a wealth of experience in the management of diabetes and its related conditions. And she continues to contribute to the health sector as a facilitator with the Continuous Education Service and also as an executive member of the Diabetes, Endocrine and Metabolic Society of Ghana. She has contributed to extensive work within this field. She's always willing to share of her experience and her qualifications at any given time. She has contributed immensely to this field. She's of course married with 4 children and has interest in educating healthcare professionals such as yourselves and the general public on diabetes and endocrine disorders. So please, a round of applause in the chat for Dr. Cecilia. You better clap before she changes her mind about teaching us today. So please, I want to see the applause in the chat. Thank you, Barbara. Yes, very good. We also have Dr. Charles Donkor-Baah, who is an endocrinology fellow in training at the Korle-Bu Teaching Hospital. He is a physician specialist and a member of the West African College of Physicians and the Ghana College of Physicians. He's also a member of the Diabetes, Endocrinology and Metabolism Society of Nigeria. So we also are very pleased to have with us Dr. Charles Donkor-Baah. So I want to see claps, applause in the chat so that Dr. Charles doesn't drop off this call and say he's not teaching us again. Okay, so we'll jump very quickly into the session. We would have both of them give us information on this very critical topic, one after the other. So I know Dr. Charles would like to share his screen. Dr. Charles, can you hear us? Hi, Dr. Charles, can you hear us?
Hello, I can hear you.
Perfect. Okay, so are you ready to share your screen, sir?
Sure.
Okay, so we've enabled you to do so. So we'll stop sharing so that you can share. Please go ahead. So, sir, we've given 15 minutes, so you might hear me interject during the course of your lecture to tell you that you have 5 minutes more for your section. Okay, yes, your screen is coming up now. If you can put it on presentation mode so that we can also see it. Hi, Dr. Charles, can you hear us?
Yes, I can. I'm trying to put it in slideshow mode.
Okay. So at the bottom, I think you'll be able to see the icon at the bottom of your screen for you to be able to put it on slideshow mode. Or would you like us to share for you on slideshow mode?
I will, just that I can't find the slideshow button here. Let me see. Okay.
So, sir, if you go to the top left of your screen.
The top left.
Good. Top left, right where you have save, the save icon, just the very top left. Yes.
Yes.
So Go back up, go up higher. So you can see the
Yes.
NOSA go up.
Uh-huh.
Yes. So then go right. You can see something that looks like a presentation after the undo icon.
Yes.
Yes. So the next one, go right, go right. Right. Yes. There you go.
All right.
Perfect.
Great. There is another, there is something appearing on the screen, which is actually obscuring my view.
Okay, is it the floating controls again?
Yes, I've actually gone there.
Sorry, sir, could you repeat that?
Okay. All right, so that's fine. I think I'm okay now.
Okay,
Please,
perfect.
can you see my screen?
Yes, we can.
All right.
And could you please put your video on if possible, sir? Thank you so much.
Unfortunately, it is still obscuring my view.
Sir, can we share the screen for you just so that it's easier? So maybe it might be because of the mode that you're sharing in. Can we share the screen so that you can go ahead?
All right, okay, you can. That's fine. Unfortunately, it's still there to my right. So those, so I can see Frank, you will see Elizabeth and Bonsa. It's actually taking a portion of the slide.
Okay, can you draw? So you're seeing the participants in the
yes.
Okay, so if you look at the line, there is a line. If you hover your mouse, you would see that you can drag the screen to the right to reduce the space for the participants and increase the space of the screen. Can you see that?
Let me see. To the right, you said?
Yeah, so just pull it towards the right. It will increase the space for the screen. Can you see that now?
No. Sorry about this.
How about you use the minimize button? So there's a,
okay, I think it's fine. It's fine now. It's fine now. Is my video on? Hello?
Yes, it is, sir. Please go ahead. Just tilt the camera slightly down so that we can see your face. Perfect. Please go ahead, sir.
All right, good afternoon to you all. Sorry for the slight hitch. Welcome to this afternoon's webinar. So my name is Charles Donkor-Baah, and like was mentioned, I'll be doing this presentation with Dr. Kootin-Sanwu. So I believe you all agree that diabetes in pregnancy, it's an important topic for us to look at this afternoon. One, because it's quite a common condition that we quite often see in our day-to-day practice. But more importantly, various studies have demonstrated that hyperglycemia in pregnancy, if poorly managed, is associated with poor pregnancy outcomes. So it is important that we are all conversant with the proper and holistic management of cases of diabetes in pregnancy to ensure better outcomes for the mother and then the unborn child. All right, so without wasting much time, so this will be the outline for the presentation. We would look at introduction briefly, then we'll look at how hyperglycemia in pregnancy is classified. look at some risk factors for gestational diabetes, and we'll touch on diagnosis and complications. And then we'll zoom in on management of hyperglycemia in pregnancy. And then we'll conclude with some key messages. Next slide, please. So by way of introduction, diabetes mellitus, as we all know, is a chronic metabolic disorder that is characterized by hyperglycemia due to absolute insulin deficiency, as may be the case in type 1 diabetes, or decreased insulin production, often on the background of insulin resistance, as may be in the case of those with type 2 diabetes. Now, as of 2021, the International Diabetes Federation estimated that over 500 million people were living with diabetes globally. Again, over 200 million women between the ages of 20 and 79 have also been estimated to be living with diabetes globally. And so you can tell that these women in their reproductive age group, of course, when they get pregnant, definitely they will present as cases of hyperglycemia in pregnancy. So like I said, it's quite common in our day-to-day practice. Now, the prevalence of diabetes in pregnancy is actually increasing worldwide. And this is in keeping with the global epidemic of obesity, which we are witnessing now. And as we all know, obesity is an important risk factor for type 2 diabetes and gestational diabetes. In 2019, some 20 million live births were associated with some form of hyperglycemia in pregnancy. Next slide. Now, the prevalence of diabetes in pregnancy globally was estimated to be a little over 15%. And what is interesting to note here is that majority of these cases actually occur in low and middle income countries. In a study done by at the Kolebu Teaching Hospital, they found the prevalence of gestational diabetes to be 10%. And in another study, they found the prevalence to be a little over 13% in Africa. Now, it is important to note that hyperglycemia in pregnancy is associated with adverse maternal and fetal outcomes. And it actually has long-term health implications for the mother and the child. It is also instructive to note that even in advanced or developed healthcare systems, when you compare non-diabetic pregnancies to diabetic pregnancies, complications such as stillbirth, congenital malformations are about 5-fold higher in diabetic pregnancies. And improving pregnancy outcomes in these cases actually depends on good glycemic control, right from the preconception period, and this ought to be maintained throughout the period of pregnancy itself. However, the real challenge is to ensure that women who have diabetes actually plan and prepare very well for their pregnancies. Next slide, please. So how do we classify hyperglycemia in pregnancy? So according to the World Health Organization and the International Federation of Gynecologists and Obstetricians, hyperglycemia in pregnancy should be classified as either pregestational diabetes, diabetes in pregnancy, or gestational diabetes mellitus. And this is a slight shift actually from the traditional way of classifying hyperglycemia in pregnancy, where it is classified just into two groups, i.e. pregestational diabetes and gestational diabetes. Can you please go back a slide? So this new classification is actually important to distinguish cases of overt diabetes, which are first diagnosed in pregnancy, from lesser degrees of hyperglycemia, which are referred or are classified into the group gestational diabetes. So pre-gestational diabetes, in this case, includes those who are known to have diabetes before getting pregnant. So they may be type 1, they may be type 2, or the other rare forms of diabetes, including monogenic diabetes, for example. Now, the designation diabetes in pregnancy, which is also known as overt diabetes, actually stands for those who are first diagnosed with diabetes in pregnancy. But here we are looking at the diagnostic values being comparable to what we use in the non-pregnant population. Whilst those who have lesser degrees of hyperglycemia, first diagnosed in pregnancy, we classify them as gestational diabetes. So typically, for those with gestational diabetes, their values are comparable to what we use for intermediate hyperglycemia in the non-pregnant population. Next slide. So this new classification is important for two reasons. One, it is important to distinguish between higher degrees of hyperglycemia from lesser degrees of glucose intolerance or hyperglycemia in pregnancy, because the level of glycemia actually determines the pregnancy outcomes. Instead of lumping all of them in terms of those first diagnosed in pregnancy, whether their sugars during diagnosis are so high or not, lumping all of them together as gestational diabetes. The second important reason why this classification is important is that those who have higher degrees of hyperglycemia need to be assessed for chronic complications of diabetes. And these are the people who are also likely to require pharmacological intervention. Next slide. Next slide, please. So now let's look at some metabolic changes that occur in pregnancy. First, we should appreciate that the hormones of pregnancy, i.e. progesterone, estrogen, human placental lactogen, human placental growth hormone, they all work in concert to increase the nutrient requirements of the fetus in pregnancy. So in pregnancy, the beta cell mass of the pancreas actually doubles. And this results in increased insulin secretory capacity of the mother. Fasting plasma glucose declines by the 8th week of pregnancy, and it reaches the lowest level by the end of the 12th week. Now, maternal insulin sensitivity declines. In other words, maternal insulin resistance begins from the mid-second trimester upwards. So for the mother to maintain normal glucose tolerance around this period, it is imperative that the mother is able to increase the insulin production to overcome this resistance. Next slide. So this is what happens in normal pregnancy, what I've just described. So the only reason why people who are normal, in quotes, go through pregnancy and do not develop hyperglycemia is that during the period when there is insulin resistance, that is the late second trimester going into the third trimester, these women are able to compensate by increasing their insulin production. So for those who develop diabetes during pregnancy, you can infer that during the period of insulin resistance, they are not able to compensate by increasing their insulin production. And so that underlines the pathogenesis of gestational diabetes. Again, you can also infer that for those who already had diabetes before getting pregnant, once they reach the late second trimester, going into the third trimester, because of the insulin resistance that occurs, you will soon realize that they will need increased doses of insulin in order to maintain normal sugars. Again, in pregnancy, because of the insulin resistance that occurs, there is increased lipolysis. Lipolysis basically means increased breakdown of fat And with this, you can have the free fatty acids being converted to ketone bodies. And so people with diabetes in pregnancy are susceptible to developing diabetic ketoacidosis. And DKA can develop rapidly, and this can actually occur at low levels of hyperglycemia, and if left untreated, leads to high fetal mortality. So now let's look at gestational diabetes. So like I described earlier, the reason why some women will develop diabetes as diagnosed during pregnancy is that they are unable to compensate for the insulin resistance that develops in the late second trimester into the third trimester. Now, GDM has traditionally been defined as any degree of glucose intolerance with onset or first recognition during pregnancy. And this definition, this traditional definition is important. So the any degree there actually refers to any level of hyperglycemia. So it may include those with high levels of hyperglycemia, all being classified into the group of gestational diabetes. So that is why I explained that the WHO and FIGO, and actually the Endocrine Society as well, they've all tried moving away from this traditional definition of gestational diabetes. The reason
Hi,
being
Dr.
that,
Charles.
hello.
You have 5 minutes more.
Wow. So this definition actually has some limitations. First and foremost, those cases of hyperglycemia, severe hyperglycemia diagnosed for the first time in pregnancy actually represent cases of undiagnosed pre-existing hyperglycemia. And the severity of hyperglycemia is also clinically important with regard to both the short and long-term maternal and fetal risk. So we know that studies have demonstrated a continuous relationship between degree of hyperglycemia and pregnancy outcomes. So the higher the level of hyperglycemia, you can infer that the pregnancy outcomes will also be worse off. Next. Now, let's look at some risk factors for gestational diabetes. So being overweight or obese actually puts you at a higher risk for developing gestational diabetes. So women who have a history of polycystic ovarian syndrome are also at risk. Previous delivery of a macrosomic baby, so a baby weighing 4.5 kilos or more, puts the mother at risk of developing gestational diabetes. And even if they've had a previous history of pre-diabetes, that is impaired glucose tolerance, impaired fasting plasma glucose, they are at risk of developing gestational diabetes when they get pregnant. Other risk factors include hypertension, increased triglyceride levels, low HDL levels, a family history of diabetes in first-degree relatives, and then high risk ethnicity. So some ethnic groups are considered to be high risk for developing diabetes. This includes a Black race. So from the word go, our women in this part of the world are at high risk of developing gestational diabetes once they get pregnant. Again, those who are physically inactive are at risk of developing gestational diabetes. Next slide, please. So how do we screen for gestational diabetes? So the recommendation is that all pregnant women should be screened for gestational diabetes between 24 and 28 weeks of pregnancy with a 75-gram OGTT. OGTT is oral glucose tolerance test. And this actually includes those who are screened in early gestation, let's say the first trimester, and have a negative test result. They are supposed to be screened again when they get 24 weeks with an OGTT. Now, for those who are considered to be low risk, after screening them in the first trimester, you may decide not to screen them again during the 24 to 28 if they were found to test negative. And to be considered to be low risk, you need to fulfill all the criteria outlined here. So you should be less than 25 years, You should have a normal weight. You should belong to an ethnic group that is considered to be low risk. And like I said, for those of us in Africa, we are, from the word go, considered to be at high risk. You shouldn't also have any first degree relative being diabetic, and there should be no history of abnormal glucose tolerance. And there shouldn't also be any previous history of poor obstetric outcomes. Next slide, please. So how do we make a diagnosis of hyperglycemia in pregnancy? So the WHO recommends that the diagnosis of gestational diabetes be made at any time. So that phrase, at any time, it's very important during pregnancy, based on one or more of the following. So at any time during pregnancy, if you do the OGTT and you find a fasting plasma glucose to be between 5.1 and 6.9, you can diagnose this woman as having gestational diabetes. If the 1 hour post-glucose load is 10 or more, you can diagnose them as gestational diabetes. And if the 2 hour post-glucose load is between 8.5 and 11, you can diagnose them as having gestational diabetes. So any one of them, if present, can make you designate them as having gestational diabetes. Now, what about diabetes in pregnancy? So, like I mentioned, diabetes in pregnancy is the same as overt diabetes, which is first diagnosed during pregnancy. And the WHO recommends that this diagnosis can also be made at any time, so including the first trimester. Okay, we say any time, so the first trimester, second trimester, or third trimester. If one or more of the following criteria are met. Now, if the fasting plasma glucose is 7 or more, you can make this diagnosis. And once you find this, in fact, it has to be repeated at another time for confirmation. If you happen to do the OGTT, then a 2 hour plasma glucose load of 11.1 millimole or more can also help you make this diagnosis of diabetes in pregnancy. Now, for those who have symptoms, you can just do an untimed or random plasma glucose. And if the value is 11.1 or more, then you can make a diagnosis of diabetes in pregnancy. Next slide, please.
Hi, Dr. Charles. So time is up, but I'll give
Yes,
you
I'm
one
running
extra
up.
minute.
Yes, I'm running up.
Thank you.
So this slide is basically looking at the guideline differences. Okay. So if, unfortunately, can you see my cursor? Unfortunately, you may not see because I'm not the one sharing.
Yes, we can. Yes, we can.
Okay. So if you look at these various bodies, Endocrine Society, National Institute of Health and Clinical Excellence in the UK, AD, American Diabetes Association, WHO, and then FIGO, they all agree that some screening has to be done in a prenatal or antenatal period. However, the differences lie in, one, the timing, when to do it and what method to use. If you look at the WHO here and the timing, you can see that at booking, you can actually do your OGTT, or for those who have symptoms, you can do your random plasma glucose. And if they meet the criteria for gestational diabetes, you diagnose them as such. If they meet the criteria for diabetes in pregnancy, then you diagnose them as such. But if you look at the NICE guidelines, for example, you can see that for booking, you only have to do OGTT for those with a previous history of gestational diabetes. Otherwise, they advise that you do the OGTT strictly at 24 to 28 weeks. Again, the diagnostic cutoffs are different, looking at the NICE and then the WHO criteria. So for the NICE guidelines, the fasting plasma glucose should be more than 5.6, should be equal or more than 5.6 millimole. Then your 2 hour post-glucose load will be 7.8 or more. Okay, and here they also leave it open. So fasting plasma glucose of more than 5.6 would mean more than 7 or 8. So with the NICE, for those who have fasting plasma glucose pregnancy of about 8, if they are first diagnosed in pregnancy, they are still classified as gestational diabetes. So that is where some of the slight differences come in when you look at the various international bodies. So zooming in again on the diagnostic criteria, I think we've already gone through. So if you are diagnosing somebody with the diabetes in pregnancy, like I mentioned, you need to repeat it at another time. But for gestational diabetes, the test can be carried out just once. And if they meet the criteria, you can diagnose them as such. Next slide. Next slide, please. Hello, next slide, please. So that's my last slide. So looking at the complications. So what are some of the complications of diabetes in pregnancy? So the complications can be broadly divided into maternal and fetal. So under maternal, you have hyperglycemic crisis. So they can develop DKA. And it's important to note that the DKA can develop even at lower levels of blood glucose. It can happen in type 1 diabetes patients as well as type 2 diabetes patients. Remember that anybody who is on anti-diabetic medication stands the risk of going into hypoglycemia. So it is a risk that we should always entertain. Other complications include retinopathy. So this retinopathy can develop during pregnancy, for the first time. But for those who already have established retinopathy, you should remember that it can actually worsen or progress during pregnancy. And then mothers who have gestational diabetes are also at increased risk of developing type 2 diabetes in the future. In fact, about 50% of those who have gestational diabetes will go on to have type 2 diabetes in the next 5 to 10 years. These mothers are also at increased risk of developing cardiovascular diseases later in life. Now, under the fetal complications, so like you can see, preterm delivery, fetal malformations. And again, I want us to know that the fetal complications occur quite early in pregnancy. We know that organogenesis occurs between the period of the 3rd week up to the 8th week. And so it is crucial that those with diabetes have very good control going into pregnancy, because what happens most of the time is that when mothers notice they are pregnant, they are already 8 weeks or more. And at that time, organogenesis is complete. So if they had hyperglycemia, then it increases their risk of fetal malformations. And this includes neural tube defects. So anencephaly, they may have spinal bifida. They are also at increased risk of having cardiac abnormalities. So tetralogy of Fallot, they may have ventricular septal defects, etc., etc. And these children are also at risk of developing obesity later in life. Children born to mothers with diabetes are also at increased risk of developing type 2 diabetes later in life. So we can appreciate from this slide that the complications are actually myriad. And so it is important that we manage persons with diabetes who are pregnant very well to prevent these complications. So I'll end at this point and let my colleague, Dr. Kootin-Sanwu, take us through the management.
Thank you so much, Dr. Charles. Hi, Dr. Cecilia. Can you hear us?
Yes, I can hear you. Can you
Wonderful,
hear me?
loud and clear. Please take it away.
Perfect. Thank you. So I have 15 minutes. I'll try and stick to time, hopefully. I'll just turn on my video. Can you see me? I hope.
Perfectly with your beautiful glasses.
Oh, okay. Okay, so thank you for the opportunity to educate. Dr. Donkor-Baah, I'm grateful that you set the tone. And so I'm going to continue from here, and I'm going to look at how we'll manage our patients after they've been diagnosed with gestational diabetes or diabetes in pregnancy for that matter. So after you made the diagnosis, then there must be some post-diagnostic testing that you need to do. And so for your post-diagnostic testing, you want to do this within the various trimesters, and every trimester would have different tests that may be indicated in these trimesters. So post-diagnosis, first trimester, it's important that you check your HbA1c. HbA1c is not a good test to be used for management in pregnancy, but then at least it gives you an idea of the risk that is associated with that pregnancy so that you can plan for that. The other important things to do is to assess your renal function by doing your BUE and creatinine, and then also you could do a spot urine protein to creatinine ratio test, and then a thyroid function test. Not all guidelines recommend this, but it's important because, again, remember that in type 1 diabetes, which is an autoimmune disease, sometimes they may run parallel with other autoimmune conditions. And then also your baby's brain development depends on your thyroid hormones, especially at the beginning of pregnancy. So you want to be sure that this mother's thyroid hormones are normal. And then throughout all the trimesters, you want to monitor the capillary blood sugars very carefully so that you can get to target blood glucose. Next slide, please. And in the second trimester, again, if your first trimester spot protein to creatinine ratio was high, you want to repeat this in the second trimester. Again, repeat your A1C, and all through, again, your capillary blood sugar is what will make you know whether you are doing well with your management or not. The other thing I should have said in the first trimester was to do an ultrasound to look at the viability of the pregnancy and to date this pregnancy so that you can know when to deliver the mother of the baby. And then also a second trimester ultrasound scan is indicated to look at the baby's growth. And so you are looking at around 18 to 20 weeks, looking at a growth ultrasound scan. If this mother's A1C was elevated in the first trimester, then it's important to do a fetal echo. You are interested in looking at the 4 chambers of the baby's heart to determine whether there's any congenital cardiac malformations or not. Then on to the third trimester, you want to do an ultrasound scan every 4 to 6 weeks, looking at the growth of the baby. That will also help you to determine whether the baby is growing too big, whether you want to deliver this mother a little earlier than term, or whatever you want to do, so that you know how well the baby is growing as well. If your mother had GDM, the minimum that is required is to at least do an ultrasound within one ultrasound between 36 and 37 weeks, also to look at the baby's growth. Again, for a mother who has had a long-standing diabetes or who has microvascular disease, then it will be important to assess that mother's heart by doing an ECG and an echo for that mother. Next slide, please. Okay, now to the meat of the management of diabetes in pregnancy. And it always starts with preconception care, because you don't want to wait until the patient is pregnant. Glucose is all over the place before you start trying to achieve a good glycemic control. So you want to start this in a patient who is already known to have type 1 or type 2 diabetes. You want to start a preconception care. They have to plan for their pregnancy. There's nothing like accidents in patients who have diabetes as far as pregnancy is concerned. So they need to plan for it. And so for every person who is in a reproductive age, who is sexually active, you want to talk to them about the risk associated with diabetes in pregnancy so that they can get as good a control before they embark on the journey. And so you want to give them an effective contraception until they are ready to have a baby, all right? And then before they get pregnant, you have to get them to a good A1C control before they do so, so that all in a bit to minimize your risk. The other thing that you need to talk about is the glycemic target when you're doing the preconception care. And again, remember that your patient must be screened for comorbidities and complications, especially as far as retinopathy and nephropathy or renal impairment is concerned. And you will see that there's a group that may be referred to the nephrologist when they are pregnant and they are in that category. Always a multidisciplinary approach is what is needed. Elsewhere, there's a joint antenatal care and a diabetes clinic at the same time in the same space, where there's a diabetologist, where there's an obstetrician, a dietitian and all that, so that the patient is at one spot and can get all the care that they need. So this is also important to do. Next slide. All right, so I said retinopathy, because pregnancy will increase your risk of retinopathy if you have a pre-existing retinopathy. And also the other point is, if you are going to have a rapid decline in your glucose control, or you're going to get to a tight control in a very short period of time, then the risk of retinopathy worsening may be high. So you want to screen your patients for retinopathy by doing a dilated eye examination. Usually they will use a tropicamide to do that and look at the back of the eye and see whether patient has got some retinopathy or not. Guidelines may differ. Some may say that if they haven't had a screen in the past 6 months, do it at the time that they book for antenatal care. And then every trimester onward, you want to do it to see whether it's worsening or not. Others may say do that, and then within 16 to 20 weeks, repeat it, and then sometimes 28 weeks, repeat that as well. And then the test to do for the nephropathy is as stated. If you did it and your creatinine was more than 120 uromoles per liter, or you have an albumin creatinine ratio more than 30 milligrams per millimole, or your eGFR was less than 45, then these patients are candidates that will be referred to the nephrologist so that he can keep a closer eye on their renal function as well. Remember that all potentially harmful medications in pregnancy must be stopped before they embark on the journey. Folic acid is a must for all these patients in a bit to reduce the risk of neural tube defects. And so commonly you want to start this 5 milligram folic acid 3 months prior to conception, and then you continue all through the first trimester as well. Next slide, please. Okay, so we look at the various guidelines, and they are fairly, the same, but a few differences here and there. And so for Endocrine Society, for NICE, for American College of Obstetricians and Gynecologists, they all encourage that we do all these things: retinal screening, renal screening, and then the folic acid for supplementation as well. The other thing is the thyroid function test, as I spoke about earlier on. NICE is silent on that, but for Endocrine Society and American Obstetricians and Gynecology, they all say that we need to do the TSH so that we know that the thyroid function is fine. And again, already I mentioned the criteria for referral to a nephrologist. Again, as I was speaking about a retinopathy screen, also the timing may be different, but at booking, everybody needs one, unless they've had a screen in the past 3 months or 6 months, as per NICE. And then later on, every trimester for Endocrine Society and for the Americans. And then for NICE, it will say that if there's any diabetic retinopathy at booking, you repeat this test with, at 16 to 20 weeks. But if there are no signs of that, then you want to repeat it at 28 weeks and going forward. Next slide, please. So then let's look at what glycemic targets we are looking at, all right? So you've decided, okay, this patient has got DIP or has got gestational diabetes. We need to set targets for the patient so that when they are doing their self-monitoring of blood glucose, they'll be able to know whether they are at target or they are not at target. Again, it's important that there's never a one-size-fits-all approach in diabetes. You want to do this as safely as possible so that if you can do this without getting significant hypoglycemic episodes, then of course you can make it as tight as possible. But if you think that hypoglycemia is a major challenge, then you may relax your targets a little bit. But generally, you want your fasting plasma glucose to be less than 5.3 millimoles per liter, a 1 hour postprandial glucose to be less than 7.8, a 2 hour postprandial glucose to be less than 6.7, NICE to sometimes say 6.4. So these are the targets that you are looking at, and your patient must monitor these sugars rather frequently so that they can get to target. If your A1C, ideally you should be less than 6% to avoid all the complications. But if you can't do this safely, then you may again relax your glycemic targets. For patients who are on multiple insulin injections, who are at risk of getting hypoglycemias, and they can get severe hypoglycemias, sometimes in pregnancy, they may be hypoglycemic unaware. You want to give them a continuous glucose monitor so that if hypoglycemia is happening, they can pick it early and it can be corrected. For all patients, they need nutritional counseling to ensure that they get good nutrition throughout their pregnancy. And so they need to get a balanced diet and then also try to control their sugars. So for medical nutrition therapy, what you are looking at is try and refer all your patients to the dietitian. Usually you want to they would prefer smaller meals, more frequent periods than doing large meals at less frequent periods. So usually it's recommended that they would have at least 6 meals comprising 3 major meals, 3 snacks, good amount of carbohydrates, maybe about 40%, and good amount of protein, some fats as well. But preferably you want to choose poly and monounsaturated fats, and you want to limit saturated fats and avoid trans fats altogether in the patient's meals. Sometimes there's a myth that pregnant women, they are tired, they need to sit down all the time, they don't want to do any exercises. But every pregnant woman needs some exercises, not the vigorous one that they need to run on a treadmill, but at least they can walk. So you want to encourage them to walk, and especially post-meals, they could do a 30-minute walk post-meals. This helps to reduce the postprandial hyperglycemia or the postprandial glycemic excursions that may occur after a meal. And for all of them, their weight also must be managed. Sometimes you think that because you're pregnant, you are at liberty to put on as much weight as possible. When you've got diabetes, you don't have that luxury. So we need to look at your pre-pregnancy weight to be able to determine whether you need to lose some weight, or probably if you are also underweight, you may have to gain a little bit of weight as well. Now to pharmacotherapy. For patients who have gestational diabetes, you may need to start them on medication if their glucose levels are above the target ranges that we've spoken about, and you've tried your diet and you've tried the exercise and it hasn't worked for them to reach that target. If you had a fasting plasma glucose of less than 7 millimoles and you did your exercise and your diet, and within 2 weeks, you are not able to achieve the target, then you could add on metformin to these patients to start metformin. And then you can titrate your metformin dose to reach a maximum dose, which is 2,500 milligram in a day, and you'll continue your lifestyle modifications. Again, if after a week of this, you're still not able to get to your target glycemic control, then you may want to add on insulin to this patient's treatment. If from the get-go, you're getting a fasting plasma glucose of more than 7 millimoles per liter, then you're not now going to go through metformin, insulin, and all that straight away, because you always want to get the glycemic control as early as possible. You start straight away with insulin. But again, always remember that lifestyle modification is important. So you do this in addition to lifestyle. And then you may want to add metformin, or you may choose not to add metformin to it. Again, if your fasting plasma glucose was even less than 7 millimoles per liter, but there was a complication such as macrosomia or polyhydramnios, then you want to consider insulin straight away, in addition to your lifestyle modification and metformin treatment as well. Next slide. Okay. Remember that majority of the insulins may be able to be used in pregnancy. So, of course, the human insulins are very safe in pregnancy. NPH, regular insulins are safe. For the longer acting insulins, Determer is also very safe as an analog insulin. And then the shorter acting ones, or the rapid acting ones, you can use Lispro, you can use Aspart. Glargine may be continued in somebody who's already on probably a basal bolus, already a known diabetic, who has got a very smooth control on these medications. You don't want to now go and stop and then restart another insulin, then the patient will now have to adjust and all that. So you may want to continue that. But what is really safe is to do an MPH as a long-acting Determer, and then you can use the short-acting or the rapid-acting insulins as well. And if you did this and then you realize that your fasting plasma glucose was not at target, then what you want to start is the basal insulin, okay? Because basal insulin will just control your fasting plasma glucose. So you want to start an MPH or a Determer. You may want to start at 0.2 units per kilogram body weight. Or for simplicity's sake, you could start at 6 to 8 units before bedtime. And then you use your fasting plasma glucose to adjust the doses of the insulin with time so that you can get to target. If the main problem was your postprandial blood glucose, then of course what you want to start is either a rapid acting insulin or a regular insulin, which you would start before meals. And then you could do the adjustment again. You may start at 4 to 8 units prior to the meal, and then you would use your postprandials to be able to adjust the dose of that insulin. If both your preprandial and your postprandial glucose concentrations were not at target, then you want to start a combination of a basal bolus, a basal insulin plus a bolus insulin, or a pre-mixed insulin, which we usually call the mixed-start. And then this will control both the fasting and the postprandial hyperglycemia. Again, using the self-monitoring of the blood glucose to be able to determine whether you are at target or you are not at target, and then you can do the adjustments as indicated. And so your insulin doses will always be titrated based on the glycemia. Again, remember that if you're having challenges in the management of these patients, we are always here to help. So the physician specialist is there to help, diabetologist is there to help. You can always call and then we can help you to do the adjustments as needed. Next slide. For patients with pre-existing diabetes, whether it's type 1 or type 2 diabetes, usually insulin is a go-to medication. And so you will do a basal bolus, which will involve multiple daily injections, or a premixed insulin also may be used. And then again, you can adjust based on your SMBGs. Again, for them, the total daily insulin requirement may vary, but commonly you may range between 0.7 to 1 unit per kilogram body weight. The other thing to remember, and I remember Dr. Barnes speaking about it, is that you also need to prevent preeclampsia in these patients. And so what we want to do for them is also to use a low dose aspirin, usually at 100 to 150 milligram per day, starting at about 12 weeks, so that you reduce the risk of preeclampsia in the patients who have already pre-existing type 1 or type 2 diabetes. And of course, for those who have chronic hypertension, you always must also treat them to target. And so it's also a holistic and a multifactorial treatment you want to do for the patient who has got type 2 diabetes or type 1 diabetes in pregnancy. Next slide, please. So for the pharmacologic guidelines, differences are not also much, but then remember, we've spoken about insulin, we've spoken about metformin. They are acceptable in all the guidelines, NICE, ADA, Endocrine Society, WHO, they accept these, okay? But for pre-gestational diabetes, insulin is the first line. You may or may not add metformin as an adjunct, depending on what you're finding in your patients. But for gestational diabetes, you may start straight away. And for all of them, remember again, I always want to stress that lifestyle modification is very important. For gestational diabetes, yes, you may start with metformin, and then you will use your glycemic targets to be able to decide whether you want to add on insulin or not. The other medication that has been widely used in gestational diabetes is glyburide. And so that one has been used extensively in many places. And so you can use that for your patient. It can also be as effective as insulin in some cases. And then also, again, you always want to use your SMBGs to be able to decide whether you are a target or you are not a target. All right, so next slide, please. Remember that intrapartum, they need care as well. So during labor and then delivery, for patients who have got an overt or gestational diabetes, you want to keep their blood glucose within a strict control. So usually you want to keep their blood glucose between 4 and 7 millimoles per liter. You could do this safely by using both insulin and glucose infusions during labor. And so commonly you may use a 5% dextrose in normal saline or Ringer's lactate solution, usually at a rate of about 100 mils per hour. And then also you can set up a regular insulin at a rate of 0.5 to 1 unit per hour. And then you want to do a frequent capillary blood glucose monitoring so that you can keep them within the 4 to 7 millimoles per liter. Preferably, you want to monitor these sugars every 1 hour. And then also for patients who are diet control, they may not need this regimen at all, just a regular check of the sugars. And then you probably are good to go. Next slide. Don't forget about the child born to a mother with diabetes in pregnancy or gestational diabetes. So remember that that child is at risk of all the things that Dr. Donkor-Baah spoke about. So hypoglycemia is very important. I've had an experience with a child. A cousin of mine lost a child. She had GDM, and baby was born healthy, 3.9 kilograms at birth. Everything, healthy about the baby. Went off to sleep. By morning, monitoring had not been very good. Baby had a hypoglycemic episode in the night. by the morning, baby had died. So remember that you don't leave the baby unchecked and you don't leave them unmonitored. Monitor the baby's sugars very frequently. For babies, especially who are not able to do oral feeding, then you may need to give them IV glucose infusions so that you can keep their blood glucose at an appreciable level so that they don't get hypoglycemia. The other thing which is also very common is the acute respiratory distress syndrome, hyperbilirubinemia and all that. Keep an eye on these babies so that you can discharge a healthy mother and a healthy baby home. All right. The other thing is also that their serum calciums may be low, so you monitor them for hypocalcemia. This has been said to probably be related to hypoparathyroidism, but it is not really well established. Okay, but the calcium levels may be low, so we need to monitor this one as well. Next slide. Again, remember that the risk of the mother developing frank type 2 diabetes may be about 50% of these mothers by year 2-3 post gestational diabetes may have overt type 2 diabetes. So you don't let them go home and sleep. You want them to repeat their glucose monitoring post-delivery. So commonly, all the guidelines will say that at 6 weeks, do some form of glucose monitoring. So nice fasting plasma glucose or A1C is enough. But for most of the other guidelines, and a 2-hour 75-gram OGTT is required, so that you want to know whether this diabetes has resolved completely or there's some, it hasn't resolved, so they probably need continual care as far as the glycemic control is concerned. And then after this, if you did the OGTT and you found the patient had pre-diabetes, lifestyle interventions and or metformin to prevent future type 2 diabetes is indicated. For those who have the history of GDM, they need a lifelong screening. So for me, I tell my patients that every year when it's your baby's birthday, give that to yourself as a gift. Go and check your blood sugar as a gift to yourself so that when the diabetes is starting, you'll know it early. So once a year, they need to be screened for type 2 diabetes once they've had a GDM before. And then they need effective contraception. And again, the cycle may begin anytime they want to plan for a pregnancy. They must have a preconception care again before they go on the next endeavor. Next slide. So in concluding, the number of women who have got diabetes and are pregnant is increasing, and this is in line with the increasing prevalence of type 2 diabetes among women in the reproductive age. And maternal diabetes affects all aspects of pregnancy from the very time of conception to the timing and mode of the birth. And so patients who have got poorly controlled diabetes in pregnancy will have both maternal and fetal complications as discussed. And your preconception care is critical for women with pre-gestational diabetes and those with previous GDM as well. So women who have got GDM should be screened at 6 weeks postpartum, and then following that annually so that we can pick a probable developing type 2 diabetes before it becomes out of control. Thank you very much, and I'll end my presentation here. So these are our references. Thank you.
Thank you so much. You did great with time. Thank you so much, Dr. Cecilia. Truly appreciate it. We have